All right, good to go. Good morning, everybody. We're dwindling. Look at all these empty seats. My gosh, people are just dropping. I hope everyone's doing well this morning. We're going to continue with the appendicular skeleton today. I have, I always put like an image relevant to the lecture up at the beginning slide, and I wanted to do like a GIF, like a little animation today to put up here. And I wanted an animation of one of the joints in the body, and so I did a search for joint GIF, which will get you not results that look like this, unless you are a little more clear. I thought about putting that on there, but I'd probably get fired. So anyway, hope everyone's doing well. We're going to pick things up where we left off. In advance of class today, had some readings as well as a video. The readings and video are actually getting a little bit ahead of where we are in lecture right now. So you'll see for your program on Friday, I kind of reassigned those and basically said, if you haven't done this reading and watched this video yet, watch it for Friday. And otherwise, your program for Friday just has human anatomy in the news, which we'll get to in a second, but there's no new assignments for Friday. Also note, I sent out an email yesterday. I messed up which sections corresponded to which page numbers in the textbook in the original version of the program. I corrected it, the new one's up, and then those same sections are assigned again for Friday. So if you have any confusion about that, make sure you upload or download the newest class program so you've got that information. Any other questions before we dive in? Cool. All right, let's do it. So today is going to look like this. I've got a, random order of things here. Human anatomy in the news for you. And then I want to review a little bit about this question that I had asked you in your ticket out after class on Monday. Then we'll continue with the appendicular skeleton with the coxal bones. I've got a review activity that's not drawing today, and it's not getting up in a line from class either. And then we'll continue on the lower limb and see how far we get. And then I will talk about quiz number 2, and you'll get the results of that back after class today in Blackboard. And then I'll share some details of your upcoming exam. And then you have a short ticket out today. So a long agenda, but lots of short stuff. So should be good. So let's get cranking. So this is kind of a cool story. So there is a bone. We're going to learn about these bones in class today. We actually haven't gotten to this yet. But there's a kind of bone called a sesamoid bone. And if that looks like the word for sesame, like sesame seed, that's because that's what it's named after. Because they're like little small kind of circular or oblate bones that are found. And what defines a sesamoid bone is that it doesn't develop kind of where other bones normally develop. It actually develops inside of a tendon. Now, the sesamoid bone with which you're most familiar is going to be the patella of the knee. You saw examples of this yesterday. We'll talk more about that coming up, but that's your what's the common name for this bone? Kneecap. Thank you. These words are tricky sometimes. Your kneecap, right? Your patella. But you also have some sesamoid bones associated with the tendons in your thumb as well as your big toe. Now, there's another sesamoid bone called the fibella. And the fibella is found in the back of the knee. So this is a posterior view of the knee joint. You can see the distal end of the femur here. You can see the head, the proximal end of the tibia here. You can see the fibula here. And you can see these little bones here. So these are some radiographs, some x-rays of people's bones. And basically, the cool thing about this little sesamoid bone is that historically, it wasn't very common. So it's a small sesamoid bone that's posterior to the lateral epicondyle of the femur. So this is the lateral epicondyle, and it's just behind it, right? And historically, less than like 100 years ago, there was less than 10% of the population had this bone. And this is actually pretty easy to identify because we have medical records and dissections and things like that, dissection records. However, when they surveyed people living now, about half of us have these little sesamoid bones. So for whatever reason, this little bone is becoming more and more prominent in our population. And the reason that these researchers speculate that this bone is becoming more prominent is because, remember, I talked about bone development specifically is in response to how those bones are used and also in association with tendons and ligaments and things like that, that it's not just a static predetermined things, that these structures develop accordingly with how they're used. And they postulate that because people now are better, have received better nutrition, and are generally larger and often overweight, that this creates more pressure on this particular tendon here, and that increases the chance of that little bone developing. And oh, whoa, hey, easy there, fella. What's going on? Okay, I have a quote from the researcher here. I really like this because this sums up a lot of science. It's like, we found this cool thing. We don't know what it does. It says, one of the researchers on this study said the fibula may behave like other sesamoid bones to help reduce friction within tendons, as your patella does, for example. It might redirect muscle forces, or, as in the case of the kneecap, increasing the mechanical force of that muscle. Or it could be doing nothing at all. So basically like, hey, we found this thing. It could play a role in these things, but we're not really sure. So future research will maybe help us understand the fibula. So I have a link to the Popular Science article. It's actually really short, taking you about 3 seconds to read it on this, and then a link to the original study. I want to remind you that you can expect questions on human anatomy in the news in your quizzes and exams. You saw we had a question on redheadedness in the last quiz. However, the question will be based on what we cover and talk about in class. So I definitely encourage you. It will help you to go and read the Popular Science article I have a link to. That's usually a pretty fun and quick, easy read. I also provide the link to the original study in like the peer-reviewed journal. It's not necessary to look at that. I just provide it as a reference in case you're interested. So all of the questions will be based on what we cover in class, and it will help to understand it to read that Popular Science article. Cool stuff, the fibula. Any questions on that? Yeah, go ahead, Joe.
Do you know if in the modern study they did any kind of analyses of like the association between the people who had it and various factors like body weight or whatever?
Yes, there are some details. They looked at differences between men and women, and I don't know if they did body weight. It's in this article. I don't remember off the top of my head though. But they did find there was no differences between men and women. It wasn't more prominent in men and women. Yeah, and there's more details in there. I just don't remember off the top of my head. That's a good question, though, if they actually found a correlation between. Yeah, I don't know. Any other questions? Cool, fibula, neat. So, if you have that bone, you have more than, I mentioned at the beginning of the skeletal system that we have 206 bones-ish. And this is the reason why that's an ish on the end, because you might have this one, you might have 208 or even 210. I want to review one thing here too. On your ticket out for Monday, I asked you to name all of the bones connecting the sternum basically down to your carpals, right? And I saw some varied answers on your responses, and I want to make sure that we've got this. So the sternum, actually, it's not shown here, but remember the sternum articulates with the clavicle. Remember, you have the manubrium of the sternum is the top part. So we've got sternum here. You've got your manubrium is kind of shaped like this, and then you've got a long sternum, and then you've got this kind of triangular bit at the bottom. And so you've got the manubrium here. You've got the body is the big part here, and then you've got what's called the xiphoid process here, right? Remember that your clavicle articulates right up here with your manubrium. It kind of comes out and goes like this, right? And it's not shown here, so I'm drawing it here. Make sure you've got that. Then the clavicle, in turn, articulates with the scapula. Remember, that's at the clavicular acromial joint right here. The distal end, or excuse me, the lateral end of the clavicle articulates with that acromion process. Then your scapula articulates with the humerus. That's the arm of your antebrachium, or excuse me, the bone of your antebrachium. Remember that we have what's called the glenoid cavity, is that shallow cup where in the scapula, where the head of the humerus articulates with the scapula. And then down at the elbow, of course, the humerus articulates with both the radius and the ulna here. And then those bones extend down here. And importantly, the radius articulates with the carpals, but the ulna actually doesn't directly articulate with those carpals. Who can tell me the name of the two carpals with which the radius articulates? Give me one of them. Scaphoid, good. And the other? Lunate, good. Yep. So the two carpals I want you to know are the scaphoid and the lunate, and that's because those are the two that articulate the radius. So a correct answer for this should have been clavicle, scapula, humerus, and then essentially ulna and radius together, and then the carpals. Just want to make sure everyone's got that down. Does that sound okay? All right, let's get back to the appendicular skeleton. And actually, I want to talk about the radius and the ulna in a little more detail here. I don't feel like I didn't do a good job covering this earlier in lecture. And I want to be clear about the joints between the radius and the ulna. Remember, I said there's two joints where they articulate. There's a proximal radioulnar joint and a distal radioulnar joint. The distal radioulnar joint, there's not much movement there. That's bound really tightly. However, at the proximal joint, there's a lot of motion between the radius and the ulna, but it's in this kind of unique way. We don't have many joints in the body like this. So I want to make sure I'm explaining this well. And as you saw in lab, the proximal end of the radius has this like disc on the end. Like you can see very clearly, it's this very circular head of the bone, and it's very flattened. And that is because it essentially acts like a wheel at this proximal radioulnar joint. And when you turn your arm, it rotates. Unfortunately, you can't see it here. But what you can see is that when your arm is like this, you have your radius and your ulna. But then when you turn your arm, importantly, that ulna, it moves down a little bit here, but that ulna is essentially in the same place. What happens is the radius flips over to the other side of the ulna, and now when your hand is in this position, those bones cross over, right? So the ulna more or less stays in the same spot when you turn your hand. The difference is that the radius flips over and makes those bones cross pretty proximally here. Now, you can see that in this diagram here. When that happens, what happens is this at the proximal radioulnar joint, the radius essentially turns and rotates with this notch in the proximal end of the ulna. And so it essentially acts like as almost like a wheel turning against the ulna that rotates the radius around the ulna. I can show you what that looks like in an illustration here. Again, another joint GIF. Whoops. Gonna work? Okay, there we go. So you can see, notice that as the hand turns, the ulna, which is the bone right here, basically doesn't move, right? It's the radius that turns around it and moves with the palm of your hand. And you can see that this wheel-like joint just basically rotates right there. So we have two joints for the radius and ulna. The proximal joint, we have lots of movement as the radius rotates. And at the distal end, these are tightly bound. There's not a lot of movement there. And so those two, at the distal joint, it stays in the same position and rotates with the rest of the hand. Yeah, question?
So is the fibrocartilage between there allowing that, like, what kind of cartilage is between the ulna and the humerus in there?
The ulna and the humerus.
Sorry, the radius.
Radius down here, or?
The one on the top.
Up here. Okay, that's right. You have a ligament that surrounds this, the circular head of the proximal end of the radius that basically acts like a band that goes around. It's almost like a wheel and pulley kind of system. And then, of course, both of those bones are covered in hyaline cartilage. And that cartilage provides structural stability, but also reduces friction. Remember, hyaline cartilage is like more slippery than ice. So it allows that to rotate without any friction. Yeah, that's a great question. Remember, between these two bones here, wait till it opens. Along here, there's fibers that bind these two bones in position. What is that called? Refresh your memory. Go ahead.
Interosseous membrane.
Yeah, the interosseous membrane is the connective tissue that goes between those two bones. Keeps them tightly bound together. Good. Questions on that? All right, it's kind of a cool joint, and it's pretty unique in the body, and I don't feel like I did it justice the other day, so I want to go back and make sure we got that. So we left off last class, we talked about the carpals. What I want to move on to is talk about the more distal bones of the arms, and specifically that is going to be the metacarpals. There's not too much to say about them. These are the bones of your palm, and rather than give each of these an individual name, they're numbered 1 through 5 with Roman numerals, beginning with your thumb or your pollex. So that's going to be important to remember, that 1 is always going to be your pollex. And this is important for your phalanges, your finger bones, that we'll see in a second. These metacarpals articulate with the distal row of the carpals here. And you can see that is the joint that is inside of your wrist. It's basically like the bottom of your palm right here. And you notice that they kind of radiate outward from those carpals. I'll give you a second to get those notes to see everyone writing. So again, the metacarpals are the bones of your palm. So these are all the bones between about here, right up to your knuckles right there. Then moving distally from there, we have the phalanges. It's a funny word. The singular is, well, I'll just write it over here. Well, that's pretty hard to see. Is it up there? Okay, so the singular, yeah, let me just write it over here. The word phalanges is plural. And so we have what's called phalanx is singular, and we have, there are two L's in front. Yeah. And but phalange has just one phalange. It comes from the Greek or Latin. I don't remember which is the root. It comes from these like rows of soldiers, so they'd be like lined up in a row, and so these bones are lined up in a row. Again, these are numbered 1 through 5, same as your metacarpals here. Again, beginning with the thumb at number 1. Each finger, except for the thumb, has 3 phalanges. We have a proximal, a middle, and a distal, right? So proximal, middle, and then the distal, your little fingertip up there. And each of those has that pattern, except for the thumb, which just has proximal and distal. It doesn't have that middle bone. But it does have 2 small sesamoid bones right here, which is basically right in this part of your thumb where your thumb attaches to your palm of your hand, basically. These 2 little sesamoid bones in the tendons that either generally provide a kind of an anchoring point for the movement of the thumb, because the thumb is the strongest of the digits and kind of acts a little bit differently than the rest of them. We have opposable thumbs, so we can grab stuff, throw stuff, climb stuff, all the fun things we can do with the thumb. We can hitchhike with the thumb. We're the only animal that hitchhikes, which is cool. And so we describe this phalangeal formula as 2, 3, 3, 3, 3, which basically means that in the order of digit 1, 2, 3, 4, 5, digit 1, the thumb has 2 phalanges, digit 2 has 3 phalanges, digit 3 has 3 phalanges, and so on. For us, that's not terribly important, but if you take a comparative vertebrate anatomy course, for example, you'll see that lots of different vertebrates have lots of different formula for those digits, and it becomes important for how they work functionally. But for us, what I want you to take away is that we've only got the 2 phalanges in the thumb and 3 in the rest of the fingers. That's what I got. Questions? Upper arm? I want to see one thing. I have an activity here. I want to decide if I want to do it now or later. I might just skip ahead here. Let's just do this review activity now. I'm going to skip ahead a little bit. What I'd like you to do is take 3 minutes. There's a QR code. I've given you a couple slides in Google Slides. And what you can do is just take some time to label those. You can draw it on your notes. You can redraw the picture. You can just draw it digitally. You don't have to actually draw anything. What I want you to do is just label those parts and make sure you've got it. And now you also have a slide that's a resource to study from. So I'm going to give you 3 minutes to go back and label those parts of the humerus, and then we'll bring it back together. I wasn't sure what the best way to do this digitally would be. I guess you could take a screenshot and then use like the editing on your photos to just write on it or draw on it or whatever works. Okay. At the end of class, you will, yeah. Yeah, so save the image at the end of class, we'll submit it with your, yeah. You got it? Nice. From class the other day? Oh, you did, okay. Perfect, good. You're a step ahead. See if you can do it then, just quiz yourself, mentally. Go through and make sure you can fill in those blanks and stuff then. You guys goes into? All right, there's 3 minutes. Let's go ahead and see what we've got. There we go. So you should have something that looks like this from the posterior view. You have the head of the humerus, the greater tubercle, the radial groove, the deltoid tuberosity, which is this kind of rough spot right here. It's important attachment point for your deltoids, which is this triangular muscle on your back. You'll see that coming, or trapezoidal muscle. No, I'm sorry, that's the big muscle over your shoulder. Sorry, I got that mixed up. The deltoid is a big muscle over your shoulder, and so it attaches this tuberosity here. We then, of course, have the olecranon fossa. So remember, the olecranon is that proximal end of the ulna and articulates with the elbow. So that's where essentially that locks in there. We have the medial and lateral epicondyles and the trochlea, which is this really smooth cylindrical bit that fits right into the olecranon of the ulna. So make sure you've got that. And then looking at it from the anterior view, you've got the lesser tubercle, and you have the intertubercular sulcus. And so that is where a tendon for your biceps runs kind of between the greater and lesser tubercle. We then have the coronoid fossa and the radial fossa, where we have the articulations with the ulna and the radius. And then we have the capitulum, which is this kind of circular part here that articulates with the radius. So lots to know on your humerus. You can definitely expect a question on the exam that looks like this, that says, draw an image of the right humerus from the posterior view and label the following features. Or draw an image of the left femur from an anterior view and label the following features. And so you'll draw out the bone and label certain things, making sure you get the right bone and you get it from the right aspect, knowing which is the left and which is the right. All right, bit of review there. Now you have those Google Slides you can use as well. What questions do you have? You good? All right, I'm going to go back then to our pelvis. All right, so next I want to move on to the bones of the lower limb, starting with the pelvic girdle. The pelvic girdle is defined with 3 bones. We have a left and a right coxal bone, or hip bone, as they're commonly called, and we have the sacrum, which is in between those 2 bones posteriorly. We also have the coccyx down here, which is not part of the girdle properly, but is attached to the sacrum as well. And so what is important to know about the pelvic girdle is that it is what attaches our lower limbs, our legs, to our spine, and therefore our torso. And it also supports the weight of all of these organs that are in our abdominal cavity, and also, in a way, the organs in the thoracic cavity. So we have this structure that plays these multiple important roles as bridging the lower limbs to the rest of the body, but also support for all of the organs in the center of the body. There's a lot of features of this. We're going to talk about this in great detail in the lab, but I want to start off with a couple things here in lecture. The first is that you might remember the pubic symphysis is where these 2 coxal bones articulate anteriorly, and that is made of fibrocartilage. Remember, that's a really tough cartilage. I want to talk about injuries to this joint in a minute here, but I want you to know that that articulates there. Very, very little motion there at all, hopefully. And the same is true at these sacroiliac joints, the joint between the coxal bone and the sacrum. Those bones are not fused, but they're very, very tightly attached. And they're attached by a very strong ligaments that kind of bind everything together. The other feature I want to point out in this slide is that we have something called the acetabulum. This is, you can't really see it from this angle, but it's like a cup in the hip bone where the femur articulates. And it's a much deeper cup. It's analogous to the glenoid cavity of the scapula, but it's much deeper than that. And we have a lot more strength and stability in our hip joint than we do in our shoulders. And you'll see comparatively, a major difference between the pelvic girdle and the shoulder girdle is just the trade-off between flexibility and strength. We have a lot more flexibility in our shoulder girdle, but again, that can be problematic because it's prone to dislocation or injury. It's not very tightly attached to the axial skeleton. The pelvic girdle is the opposite. It's very, very tightly attached to the axial skeleton. We have a lot less flexibility at those joints, but in turn, we have a lot more stability because that is bears a lot more weight generally than the joints of the shoulder girdle. So let's talk about this. The coxal bones, commonly called the hip bones, more properly called the os coxae, are actually formed from 3 separate bones when you're born. When you're born, these are separate. Actually, I'll just show you what that looks like here. You can see this is a young child. I don't know how old they are, but not fused yet. And each coxal bone is composed of 3 separate bones: the ilium, the pubis, and the ischium. And so you see in this X-ray, these spaces here, they're not actually, it's not empty space, it's cartilage is between those bones. So they're held together. It's not like they're loose and floating around. But the bones aren't directly articulating with each other. Instead, we have that cartilage between those 3 bones. As you get older, those bones fuse and they look like this. And by the time you're in your early mid-20s, you can't see any joint or anything. The bones are completely fused and it's one single bone. And however, we still refer to the parts of the coxal bone based on the names of those original 3 bones. And that's the ilium, the ischium, and the pubis. Because it's kind of a weird shaped, complicated bone, those terms are handy to identify different areas on that bone. Notice, interestingly, that this acetabulum, where the femur articulates with the coxal bone, is essentially the center point where those 3 come together. So if I asked you where the 3 bones during development that form the coxal bone articulate with each other, you could say it's directly in the acetabulum. What I want to do is walk through each of these 3 bones and talk about some of their structures and the functional importance of each of those structures. Make sure everyone's looking good here. All right, let's talk about the ilium first. This is the basically the most superior part of the coxal bone. And we have three parts of the ilium. We have the ala, which is the word for wing. We then have the body, which is this kind of thicker part inferiorly. And then we have, well, I guess the whole thing is called ilium. We also, well, let me see here. Yeah, I have a slide with a little more detail coming up. But right now I want you to know the ala is the word for wing. That's the top part, and the body is the bottom part. And there's many muscles of the legs attached here. So it's a very important muscle for the attachment of, a very important bone for the attachment of a whole bunch of muscles. And it also articulates with the sacrum right here, basically. We would have removed the sacrum, so you can see that surface right there. And it's a big joint. There's lots of overlap there. And again, it's tightly bound, so there's not movement between the coxal bone and the sacrum. So if I asked you what part of the coxal bone articulates with the sacrum, you would say ilium. Yes?
Is there any name for the part that does articulate with the sacrum?
Yes, it is. We got it coming up. Let me hold that thought. That's a good question. Okay, so we've got the ischium is next. This is essentially the, we're flipped around now, right? And so this is the posterior part. So this is a hip bone as if I'm standing like this. This is the acetabulum. My femur is articulating there. And so this is kind of the inferior and posterior part. Again, we have a body. Notice that the body of the ischium is close to the body of the ilium. We also have, this came up actually yesterday. I was struggling to come up with another example outside the mandible of where we have a ramus in the body, and we have one right here. It's this arm-like structure of the ischium that comes off. And then we have one of my favorite parts of the body, the ischial tuberosity. Not only is that super fun to say, that is the thing that you sit on. So all of you right now have the majority of your body's weight is on this part of your ischium. If you put your hand underneath your bum while you're sitting, you can feel it very prominently, especially when you're sitting, because that's where all the weight is. So this is that bone right there that's bearing your weight right now. And this is the site of origin of your hamstring muscle. So all of your muscles from the back of your leg here, the back of your thigh, don't articulate, they have their origin. They attach to this ischial tuberosity. So that's cool. Ilium, ischium, and finally, actually I have a little more about the ischium. So the ischial tuberosity, I just want to show you the muscles of your hamstrings have their attachment points there. And we'll learn more about the names of these muscles. Don't worry about it. For now, I just want you to know that we have, they're attached there. Already covered that. Yep. Just wanted to change the diagram so you can see that. Last part of the coxal bone is the pubis. This is the inferior and anterior part of the coxal bone. So now we flip this bone around again. And so now this would be my right hip bone if I'm standing facing this way. If I were to sit down, I'd put all my weight on this ischial tuberosity. Moving forward, what you see in red here is the pubis. This has a ramus here as well. It actually has two, a superior and an inferior ramus, pubic ramus. It also has this pubic tubercle. And the pubic tubercle, I'll get to that in a second. The other important feature is this symphysial surface. This is where the pubic symphysis is. So this is where that fibrocartilage is. And if you had another hip bone here, it would be articulating with that right there. The hip bone's a little hard to describe in 2 dimensions. We'll have next week's lab, we'll spend some time looking at them and kind of seeing it firsthand to better understand what it looks like. What else did I want to say? That's it for the pubis. The important takeaway is we've got these 3 bones. They fuse together, but we still call the parts of the coxal bone based on those original bone names. And so if we put them together, we get a pelvic girdle that looks like this, and you can see the pubic tubercle. I pointed out on the last slide here. You can see that pubic crest right here, and again, that's where the pubic symphysis is, right in the middle there. And we have the inferior, superior and inferior pubic ramus, as well as the ramus of the ischium here, and together these form an opening that's called the obturator foramen. And there actually, it looks like an opening here, but in real life there's like a membrane there as well. One other feature that's important, and especially is an important anatomical difference to generalize between men and women, is this pubic arch right here. And so we describe the pubic arch as this angle right here up to the pubic symphysis and back down. And we can look at this and with not entire certainty, but with a pretty good accuracy, describe whether a pelvis is from a male or a female. So you see the differences here. Female pelvis is generally wider and shallower and lighter than that of a male. And don't worry about the pelvic inlet and outlet yet, we'll get to that. Whereas the males generally tends to be taller, and so it doesn't flare out as much. And importantly, this pubic arch is very different. In an anatomically woman's skeleton, it's much broader angle there, whereas in anatomical male skeleton, it's a much narrower angle right there. And this has to do with how selection has operated with different pressures on men and women. And there's specifically one thing that women have done historically that men do not, and that is, of course, push a baby right through that opening there. And so that creates different anatomical needs for those bones relative to that of men. And specifically, not just the baby, it's the baby's head that is the primary driver of the need to have a larger pelvic basin here so that that head can pass through during childbirth. I said which is male, which is female, but I told you as we're going. One of the activities we'll do in lab next week is I'm going to give you a bunch of pelvises, and you're going to tell me if they're male or female. And you can look at them, and generally speaking, there's a few that we have in the lab that are kind of in between. I'm not 100% sure which they are, but a lot of them, it's very clear which are which. Once you get those in your hand, you'll be able to see that. Yeah.
Is there a stage early on in like adolescence where you don't really have the difference, or is that a from birth difference?
Definitely occurs during development. I'm not sure exactly how early, but especially during puberty, they change shape more dramatically as you develop. Yep, during sexual maturity for sure. But I don't know if there's a cutoff age younger than that when you could tell the difference anatomically. That's a good question. I'm not 100% sure on that. So I talked about this pubic symphysis. Remember, this is the anterior joint of the two coxal bones. It's bound by fibrocartilage. I want to just talk about what's called pubic symphysis diastasis, and that is essentially when that joint becomes damaged. And so you can see a normal pelvis here. You can see the joint right there. It looks great. But you can get a situation where it actually breaks apart. And it can be up to 10 millimeters. So that's what, 4 inches or so. So like really separate these coxal bones. And it can happen especially during childbirth if the ratio of the size of this pelvic opening to the kid's head is not optimal, we'll say. And it doesn't happen very often, but when it does, it can be very debilitating because you can expect that to be really painful and affect your mobility. Remember, this pelvic basin is supporting all of your organs above as well. It's important for walking and carrying the weight of your body, so it can create all kinds of problems. Now, this joint can be somewhat flexible during child delivery as well, and it can expand a little bit without this kind of dramatic injury. Let me see here. But when it gets too bad, the takeaway point here is that when it gets really bad, it can cause a lot of trouble, as you might expect. However, the rate of complete separation there is somewhere between 1 in 300 and 1 in 30,000. So it doesn't happen very often, but when it does, it can be obviously quite serious. especially given what we know about the cartilage, and cartilage is very slow to heal generally because it's avascularized, and so it would take a lot of time for that injury to heal, and also it would be very difficult to, you'd have to essentially remain immobile for a long time, so it could heal, which is, again, not good, especially if you just had a baby. It doesn't sound fun.
So is there any surgical correction for this?
I'm not sure exactly. As I was saying that, I was like, I wonder how they fix that surgically. I'm not sure exactly what they do. No, I won't guess. I think I'd have to look that up. I'm not sure how they correct it surgically. So as we talk about the skeleton, we've been talking about disorders of the skeleton as well. So this is just one that I wanted to share that relates to the coxal bones. So that's generally the overview. That's all I want to talk about the pelvic girdle here in class. As I said, we'll get to that in detail in lab. And again, I think a much better way to learn the features and structures on these bones is in lab when you have them in hand and can mess around with them. What questions do you have? All right, maybe this is a good spot to stop then. I've got a few things I want to go over and get your quiz stuff back, and then you have a ticket out as well. What time we got? Yeah, it's a little early, but I don't want to start this new section just yet. So we'll get to the lower limb on Friday, and then we'll pick up from joints from there. In the meantime, here are the results from quiz number 2. The class average was 28.8 out of 30, which is a 96%, which tells me that I need to make your assessments a lot harder in the future. Here's the histogram of the class. So again, the y-axis here is the number of people that got a certain score. On the x-axis are those scores. And you see like 15 plus students in the class got a perfect score on it. And a couple of you got like 1 wrong and a few trailing over here. So overall, the class did really, really well on this assessment. Nice job. A few of you have asked me in comments about getting feedback on the exams. And so I want to make it clear that if you want feedback, like especially for the longer answer questions, of course, I'll do that. What I do in the exams is I grade them often, and then I will put an example answer up so that you can compare your own answer to that example answer. And then from there, if you want to debrief, let's sit down and talk about it. And the reason I do it that way is because I think it's a much better way to give you feedback, to have you look at an example answer, compare that to your own answer, think about what you didn't include, and then if you want to take it a step further, you and I to chat about it so I can be more explicit. I feel like it's better to have that interaction to make sure you understand rather than just to put like, you got it wrong and whatever in the comments. So it's not instantaneous, but I think in the long run, that's going to help you understand the material better. I've also found, in all honesty, in the past, I've taken a lot of time to give student feedback on things like that, and it takes a tremendous amount of my time. And like 90% of the time, students either don't read it or don't care. And so this is just a way for me to be a little more efficient too, where I'm more than happy to give that feedback in great detail. I just want to make it optimal for both of us. So if you have questions or want more feedback on that, just let me know. With that in mind, now that I've showed that the quiz exam or the quiz setup was way too easy for you, we're going to go to exam number 1, which is going to be a lot harder. So this exam is going to be open all day next week, Friday. So from 7 a.m. to 11 p.m., sometime in there, a week from Friday. So that's, a week from Friday. And it is going to be open in Blackboard, and we will not meet in class that day. So this is like what you're doing instead of going to class. You can use class time for it if you want. And it's going to cover everything we cover through next Monday. So we'll cover through the lower limb, from the beginning of class, talking about anatomical terminology and histology, all the way through what we cover Monday, which will be the lower limb and probably starting into joints on Monday. As with your other quizzes, it will include a combination of multiple choice. As I said, you'll definitely can expect some drawing on there, labeling diagrams or other short answer questions. It's open book and open note, but you have to work by yourself, as with the quizzes. And just as a reminder, make sure that as you're, wait, did I have that? Yep, so work on your own there. I have another reminder, but we'll get to that. I'm going to design it to take about 50 minutes, but you have 60 minutes to complete it once you begin. And so this is a really important detail for you as you're preparing. For your quizzes, you had 3 hours. Basically, I didn't want you to be rushed at all. And so if you didn't study at all but look things up as you went through the quiz, You had plenty of time to do that for a short quiz. For the exam, you will not have time to look up the answer to every question. So it's open book and open notes, so if you're not sure of something, you can quickly reference it. But prepare for this as if it was a closed book exam. That way you can answer most of the questions knowing the answer, and a few that you need to look up, you'll have time for. So you'll have only 60 minutes to complete it. So just keep that in mind. It's a little bit of a different studying approach, and I just want to be explicit about that beforehand. The more you can prepare for this as if it's not open book, the better you'll be. And also think about a way you can consolidate your notes or references so that if you do need to look something up, you can find stuff quickly. Help keep that stuff organized. And the exam is 100 course points. So this is high stakes testing. Although remember that over the course of the semester, you'll earn 1,000 points. And so this is only a 10th of your overall grade. And so altogether, the 3 exams are only 30% of your grade. There's lots of stuff going on in class for your earning points. So it is the most points for a single assignment we'll do in class, but altogether it's still not a huge proportion of the class grade. And that's intentional to make sure that you have lots of ways you can show that you understand the material and earn those points. It's not just like these big high stakes tests, because that's not really good education. And finally, as you're looking stuff up, please stick to materials we've covered in class. Again, don't just Google search on terms or whatever, because you'll go down a rabbit hole and possibly give some erroneous information or just information that's not relevant to what we've covered in class. Questions on that? If anyone, you can feel free to arrange to take this in the testing center or wherever suits you. And that's part of the reason I'm doing this online, is then we're all not sitting in this classroom listening to each other tap our pencils. You can take it wherever suits you and whatever the best environment is for you to take the assessment. Cool. All right, I've just got a couple questions for you on the way out. Otherwise, I look forward to seeing everyone in class on Friday.